Okay, well, let's go ahead and get started. Thank you for joining. My name is Michael McKee. I'm an associate professor here at the Department of Family Medicine here at Michigan Medicine. I'm delighted to have this training session that will be focused on patients with low vision and blind. And I do have a couple sort of introductions, and I also want to acknowledge our funders. So first of all, we are really honored to get this funding through the National Institutes of Disabilities, Independent Living, and Rehabilitation Research. And our current research center is titled Advancing Health Equity Among Adults with Disabilities from Diverse Communities. And we call it AHEAD and then dash DC. And so I want to just recognize that this will be a training session that will be available recorded for later viewing and will be part of our upcoming standardized patients with disabilities. We are excited to have seven members from the community with different types of disabilities who will be serving as trained standardized patients. And the whole intent of this is really to provide training for medical students to know how to effectively communicate and care for different types of disabilities, patients with different types of disabilities. So we do have captioning available. So if you need captioning, you can select the captioning below. And also want to thank our two panelists for joining. I'm delighted to have both of them join us, and I've been really excited to work with them on different projects prior to this. So first, I want to introduce you to Renee Eccles, who is an information and referral specialist from the Disability Network of Washtenaw, Monroe, and Livingston. She's blind, and she will be sharing her perspectives as a patient and advocate. And then second is Dr. Sherry Day, is a clinical assistant professor here at the Kellogg Eye Hospital, and she is also oversees the low vision rehabilitation. She cares for a large volume of patients who are blind or have low vision, and she is a passionate healthcare advocate, especially around disability for individuals with low vision. So first of all, we're going to open it up and let Renee share some of her experiences interacting and engaging healthcare providers. And also we'll open it up for questions once she completes her session. Thank you, Renee.
Thank you. So I guess a couple things just real quick, and then I really just want to answer people's questions. I didn't come up with a like list of things to do and not do, and that was pretty intentional. The reason for that is I find that in the disability community in general, but also my experience is mostly with people who are blind and low vision is that there is such a wide variety of preferences um, and communication styles and opinions about how to interact. And so I think that sometimes we get too caught up in, am I doing the right thing? Am I following the right rule? That it can be, instead of helpful, it can be, I think, a little bit it can stultify the interaction. So I am really less interested in providing specific guidelines and more about really just providing a perspective of thinking about what it's like to interact without the visual clues and facial expressions and body language that I think people with full vision are accustomed to. So I just have a couple of things. One is to just really think about that and, be aware that the person with whom you're interacting is not going to have access to the same visual information that you would normally have access to. And that's something that I find that sighted people often aren't even consciously aware of. The other thing is to always just make sure that you are, um, when you enter a room, to say your name. I find that people in their jobs who are wearing name tags, and I don't know if this is the case with doctors or not, if they wear name tags, but often they just assume that you can see and read the name tag. Um, so always don't assume that the person knows who you are. So if you are coming into a room, just always say, um, your name. That might seem obvious, but just a quick pointer. And then um, the other thing I would say to me, which is a mistake that people often make, is um, if you are attempting to assist someone to get to a certain location, whether you're in a small room or going somewhere else, is to always um, you can offer the person to go sighted guide, and we're online, so I can't show you physically. When I'm in person with people, I will show them, demonstrate. But essentially, you want to, if the person wants to, take your arm. I think a big misconception that people will make and or mistake is they'll try to maneuver the person by touching them or pushing or pulling on them. Um, and that can be really awkward and disconcerting for a variety of reasons. Um, and then, in a related vein, I think because there's really so much variability in how people prefer to interact, I guess my best advice would just be, if you know the person has an impairment, to, just start off by saying, is there anything that you need to make this visit or this appointment as accessible and helpful to you as possible, and kind of um, empower them um, to articulate what it is that they need, because my preferences might be different based on than someone else's based on my background. To give an example, I was recently at the doctor, just a regular appointment, and the doctor was starting to type notes on a device. I'm not sure what kind of device it was, but I could hear her typing, and it set off a trauma response in me, and I asked her to please stop typing notes because I could hear it, and it was a big distraction for me. Um, so sometimes we as blind people notice sounds um, in the environment a lot more than you may be expected in sighted people. Um, so I think just being really open with the person right from the beginning to understand what it is that they need. Um, because as I said, that it really varies depending on the person's background and personality and all of that. And that's all I have to say.
Renee, thank you so much. So just I have a couple just sort of follow-up questions. You talked about the importance of not making assumptions, and that is a big concern across different types of disabilities. So could you give us some tips, recommendations on how to do that effectively? What has worked in the past for you? What has not worked well? Just in terms of what your needs, how can we meet them? Could you give us sort of an overview how to best do that?
Um, I mean, I always say to people, just always ask. Like if there's a question in your mind, um, I just think it's always better to ask. I think sometimes people are reluctant to do that because they're afraid of, I mean, and this isn't just for people in the medical profession, but anyone. I think they're just afraid that they'll offend the person. Um, but I think for me, I prefer that people ask if they don't know. So, like, let's say you don't know what the person's visual acuity is. It's okay to ask, can you see light? Can you see shadows? For me, people don't know right away that I have prosthetics, for example. So I often have to explain that to them and that I don't have any sight, I don't have any optic nerve. Um, so I think really just really asking. I think, um, yeah, I mean, and not, um, making any assumptions about, capabilities or, um, I think assistive technology is another variable. Some people are really have a lot of access to assistive tech and they use it on a, quite frequently. And there's so many new things out. I'm actually still learning about all there is out there. Um, I'm not a person that is totally up to date on all that's available. That said, I know of people who, they use, all the apps and all of the devices. So I think just again, yeah, it's just not making any assumptions about what a person has access to, and then if someone is not able to access information because they don't have that specific device, a specific strategy. Um, I think, not making assumptions about, why that is, because again, it's really based on our access to opportunities, our intersectionality with other um, identities. So I don't know if that answers your question, but I think just really just having an open mind, which I think in the current healthcare setting is really difficult because everyone's in a time crunch and it takes time to think about these things and ask questions.
Thank you so much. The other follow-up question is regarding your the distraction that you had when someone was typing.
Hmm.
So, in terms of description, sometimes I know providers or patients, when we talk about how to make it more accessible and more comforting, to just kind of give them some sort of a verbal, say, I'm
Yeah.
gonna head over to my laptop to, just to check the labs or the imaging. Just give me a second. What are some tips? Is that helpful when they do that
Yeah.
or not?
I mean, it's definitely helpful to me. I would say, like, if you're gonna take notes, you might, say kind of going back to that issue of just being aware that I don't have the same access to the visual information. So, if you're taking out your computer to write down some notes as you're talking to the patient, to just say, I'm typing here a few things that you're saying so I can, refer to my notes later. Or, whatever, or if you have like a pad and pen that you're writing on. I don't know that people don't do that much anymore, but um if you're, walking over to get a device or an instrument to use, during the exam, I think for me, the more descriptive a practitioner has been, um, the more welcoming and inclusive I've felt the person to be in their interaction. Um,
Great.
so
So, one other question, given that I am in primary care, I'm a family medicine physician, in terms of exams, so coming up to the person, listening with the stethoscope, checking your ears, otoscope, how can I make that exam more approachable for you?
I think just saying like, okay, kind of like you were saying, like describing what you're doing, um, as much as possible. Um, I don't know if, I mean, given the um requirements of, the sterility of the environment, I don't know if it's ever possible to let people, touch the items that you're using. Um, because, keep in mind that, if you're sighted, you can see the instrument that someone's using. If you have no vision at all or limited vision, um, you know, not being able to see what someone is coming at you with can be a little um, disconcerting. So yeah, I think just providing as much information as possible. Um, I don't know what um, kind of practice the students will be going in. I would say in emergent situations, it's obviously, it can be more difficult to put those things in practice, but I think just being there in the moment and providing as much reassurance as you can. I had a situation where when my first child was born, um, I had an umbilical cord prolapse in the hospital, so I was rushed to the operating room um, and put under anesthesia fairly within minutes. And in that situation, you can imagine how it can be very scary and to be able to see what is around you, and also just the amount of people around you. So, um, depending on what your role is in that situation, just to be aware that it might be more scary for someone with a sensory impairment who doesn't have the same amount of uh, access to what's going on around them.
Renee, how do you prefer to get health information from your doctor? So often we do an after visit summary. There's some sort of descriptions. There will
Mm-hmm.
also sometimes be orders. What has worked for you, and what are some tips for patients with low vision and blind?
So, for the most part now, I just use the app. I mean, Michigan Medicine has a pretty good app, so most things can be available through that. So that is really a good tool. Um, I would say as much as you can to offer those alternative formats rather than handing someone just a piece of paper. I think the biggest frustration that I have with providers is them, handing me something and just assuming that I have somebody to read it to me. Um, so that can be very frustrating. So I think um, just being mindful and offering, do you want me to email you this list of, let's say you're giving someone a list of, psychiatrists or whatever. Um, just offering the capability of, can I email this to you? Can I put it on the portal, the patient portal? Um, just being aware that, assuming that you're going to just give someone paper and that they're going to have someone read it to them is really, I mean, some people might prefer that. And there's situations where that's definitely, I have done that. Um, but I think just, saying to the person, how would you like best to get this information? And then have them articulate what it is that they prefer. And then you can decide as a provider if you're able to do that or not.
Have you experienced any stigma or attitudinal issues from providers or even medical students or trainees? If so, what were they like?
Um, I mean, I I don't think anything um comes to mind right away. I mean, yeah, I don't have anything in particular. I think it's been at times um more challenging to me as a parent with a disability than like my own care. I think sometimes there are some um assumptions made about the capabilities of people with disabilities when it comes to parenting or reproductive health in general. Um, so, and there's nothing like any specific instance that I can point to. It's just more of a, I think, feeling. So, um, yeah, I don't, there's nothing coming to mind right now, but I think it's definitely an issue.
Thank you. I'm glad it has not hopefully been a recent issue for you. We do have a question from our group. Do you prefer to use a human guide or service dog? If either, can you talk about your experiences and what has worked for you in healthcare appointments?
So I use both. So I do have a guide dog. There's definitely been cases where I've gone to a doctor without my dog. But so usually I think whether or not a person has a dog, I think it's always a good idea to ask them, how would you like me to help or assist? If I have my dog, a lot of times I will follow the provider, like if they're, leading me to another um exam room or whatever. Usually it's not the doctor who's doing that, it's the medical assistant. So I'll just tell them, I'll follow you um with my dog. My dog will follow you, or ask them to give me, verbal directions. Um so um yeah, I mean I do both depending on the situation.
Thank you so much. I appreciate all of your excellent insights and sharing a bit about yourself and just some strategies that has worked for you. I appreciate you squeezing in, this meeting. I know you have a busy schedule, so I appreciate you joining us.
Yeah, I apologize I couldn't stay for the whole thing. So
Not a problem.
I absolutely love this project, and I really hope that um, the students are, learn a lot from it. I think it's so needed, and it's just I really am so happy that you and the center are doing this. So thank you.
Well, thank you again. So we're going to go ahead, switch over to Dr. Sherry Day, and she will be able to provide some insights on the clinician side and just what has worked for patients and just some strategies, just kind of advocate for them and just talk a little bit about the work that she does. Hey, Dr. Day?
Okay, can you see my screen?
So if you want to just get it to slideshow format,
Yep.
we
Is that
can,
better?
yeah, that's great.
Okay.
Thank you so much.
Yep. And do you have a video at the end? So I have to share the sound, right? At the end. Okay, I got it. Okay, I think it's gonna work. All right. Hi, everyone. I'm Dr. Day. I'm at the Kellogg Eye Center. My specialty is in low vision. And I've been practicing for, gosh, a long time, actually. So, but let's get started. I really appreciate what Renee has said. A lot of what she has said is going to be in my slides, but I'm coming at it from a provider perspective and how we care for the patients who are in our chair, who actually enter our building. So let's see. Let me see if I can. There you go. Oop. So I want to start with some definitions. We've all probably heard of legal blindness definition, and to be specific, to be legally blind is just a number that qualifies people for benefits and services federally and on the state level. So there are two ways to be legally blind or to be deemed legally blind: visual acuity of 2200 or better in the or worse in the better eye, meaning that correction, glasses or contacts, getting them to the best vision in the eye. And then the other way to qualify is a 20-degree or less visual field. But for our intensive purposes in our clinic, we see patients of all vision levels. Renee, I think she said she's completely, she has no vision at all. But most of our patients in our clinic have some vision to varying degree. I have patients like Renee where I have to actually refer out pretty much immediately to the Bureau of Services for Blind Persons, and I'll talk about that agency later. But for our purposes, we work with patients with vision impairment. So it could be anywhere from 20/40, 20/30 to profound and vision loss. So there are some ocular conditions that I wanted to touch upon and the types of vision loss there are in our clinic. So central vision loss is quite a bit of our practice, actually. So macular degeneration is primarily an ocular disease for the older population, but there are dystrophies that also present with central vision loss, like Stargardt's, and that is more of a dystrophy. The other category is patients with peripheral vision loss. Glaucoma, retinitis pigmentosa. A lot of the patients with severe RP will have 20 degrees or perhaps less. And so therefore, it's like a tunnel vision. If you take a straw and look through a straw, that's pretty much what they have. Some patients with dystrophy will have extreme light sensitivity because they don't have enough pigmentation, like patients with albinism. And cone dystrophy, achromatopsia. And so what I have on the right of the photos on the slide are some of the filters that we can prescribe for patients, and they come in the form of contact lenses. Certain contact lens companies will make these medically necessary contacts for patients, and we'll see how that's used. And then there are other ocular conditions with a varying vision loss, and systemically diabetic retinopathy is one of them that we see quite a bit in our clinic. So they could have spotty vision. And this slide will just show you kind of what the patients see, so you have an understanding of why they can't see certain things. So for example, this first photo is somebody with kind of a moderate amount of macular degeneration or some sort of central vision. So a lot of patients will come in and say, hey, I notice your hair, but I don't see your eyes very well. They can't tell I'm wearing glasses or not. And so you can see how this presents an issue for patients for their activities of daily living. That's what we call it. And so the primary concern for patients is ability to drive. So you could see in this second photo here, it would be an issue if they really had central vision loss and they're still driving, which happens a lot, actually. So then we get into the peripheral vision, and this is varying degrees of glaucoma. The early one is the bottom. The normal is the bottom right, early to the left. And I do see extreme glaucoma in some patients, and it's not always that both eyes have equal vision loss in glaucoma. The next one is retinitis pigmentosa. So you can see how they've lost the ability to see everything around the central vision. Typically, with very severe RP, when they have tunnel vision, the central vision starts to go too, and they're roughly worse than 20/40 as well. And then this is just an example of diabetic retinopathy. They might have had some treatment, laser treatment, and so they have spotty vision. And so therefore, if you're thinking about reading a whole word, for example, a long word, they might not be able to see certain words, certain letters there. And so this slide is going to show you some of the equipment that the patient might come into clinic with and using. So this is what we call a telescope that's drilled into a pair of glasses permanently. It's a bioptic telescope. This is their view through it. So the top photo is what they see through underneath the telescope. And when they tip their head down, you see how it's mounted at an angle, right? So when they tip their head down, they will actually be able to see through the telescope at a magnified view. So they kind of have this two view through this type of telescope. Now, if you reverse the telescope, if it's not drilled into glasses, you could hold the telescope and you actually reverse it. I don't know if you guys have ever tried that, but if you look through the wrong side, quote unquote, the wrong side of the telescope or binoculars, everything gets smaller. But that's where it becomes a field expander for patients with RP, with tunnel vision. So you can expand the vision to a certain degree. However, everything gets smaller. And you'll see the photos here. I don't know if you can see my pointer, but when you reverse the telescope, the chart, you can see the entire chart, but everything gets 4 times smaller. For example, this is a 4 times telescope. You reverse it, it's about 4 times skinnier and smaller. Same thing here. So the way I use it in clinic is it's really for spot viewing for patients. So they go into a room, and I'll explain this like this. You go into a room, you step to the side, and you take your telescope, reverse it, and you kind of get the lay of the land, so to speak, and you'll see, oh, these are chairs to the right, and there's a huge table to the left. And now you understand kind of the layout of the room, the major obstacles. Patients will come in with high power readers, and it's okay for them to read this close. This is the only way it'll focus. This is one of the pediatric patients I have. So because it's such a high power reading glasses, They have to hold it close, and that's where it focuses. Here's another one. I don't just see pediatrics, but I do have a lot of adults with magnifiers to varying powers. So allow them to use the magnifiers, and some of them are lighted too. So allow them to use that if they want to read their own documents. And I had talked about earlier with light sensitivity in certain conditions. This is a girl with achromatopsia, means she has no cones. And so she's very, very light sensitive. So she is constantly wearing these tinted glasses, but it kind of impedes people from seeing her face, seeing her eyes. And as she got older, we actually fit her in those red contacts I had showed you in the earlier photo. And so that kind of opened up her face, opened up her eyes, and she was just a lot happier and confident. So these are different ways we use the contacts and devices in our clinic. So you might see patients with these. The other devices that some patients will come in with are some of the head-mounted or electronic devices. And this is by no means an exhaustive list at all. There's a lot of technology out there. And I just wanted to kind of highlight the things we do have in the clinic. Orcam My Eye is the top right. And you see it looks like a regular glasses with a frame, but the device is mounted right here on the temple. And this device, the most advanced device, has point and read options. So you'll have a piece of paper with a document. You can point at it, and the camera will pick it up and audibly read to you. The most recent, the newest version has intelligent reading, meaning you can tell it, read me the headlines, and it'll just scan the page for the headlines and read that to you versus reading the whole page. Orientation. So orientation and object detection kind of go hand in hand. So again, when you enter a room, it can tell you there's a chair, like an exam chair in front of you, table to your right. So it'll detect major objects to you. And so with patients with tunnel vision or peripheral vision impairment, it's crucial, especially if they're like in an airport. I have patients who are trying to navigate airports, and somebody's sitting on the floor waiting for their gate. Patients have tripped over people like that. So this would be a very useful tool. Facial recognition. So patients can upload faces from either Facebook or whatever apps they have, and they can recognize, 30 feet away, there's Michael McKee. It'll tell you, it's audible in your ear. It's a wonderful tool. I typically recommend this for patients with more severe vision impairment. For example, eSight is central vision loss 20/60 to 20/800 is the optimal use. If the vision's too good, you actually won't be using this because you have to get it on your head. You have to try, you have to get it. You have to learn how to use it. So a lot of patients will use it only if it's beneficial to them. Now, eSight, though, is the only one on the market that you can actually mobilize while wearing it, because it's mounted just above your line of sight. So again, kind of like the bioptic telescope, you could tip your head down and then you can use its autofocus. There's also a near focusing function on this device as well. And you can actually plug it in to do upload certain apps, but these are the basic functions of the eSight. We were using it quite well in our clinic, and we were one of the first centers to offer this about 10 years ago, but currently we can't get it through our university firewall. So that's interesting. We're hoping to get it back pretty soon. And I mentioned the bioptic telescope, and the bottom right photo is a patient with albinism. And so you can see how she's also tinted. We can tint the carrier lens, what we call the carrier lens, the glasses. And then this is another brand of a bioptic telescope. And that the central black knob here is the focusing knob. And this is the telescope right here. Now, the bioptic telescope is legal for driving in 30 of the states. In Michigan, you have to go through a specific driving, but you might see some patients that come in with this as well. And it's not just for driving, of course, it's for distance viewing. Renee talked about some people using some apps. And again, this is not an exhaustive list, but it is these are some of the apps that are useful for patients. Script Talk, and I'll talk about this later, medication management with our low vision patients. A lot of our patients are on some sort of medication, It's great that they have some people helping them, but there are times when they live independently. And some of the pharmacies, I believe Rite Aid and others, will have a script talk, which means there's an OCR reader here. You put it up to the machine, it tells you what medication is printed on the bottle. IRA is the first 5 minutes are free with IRA, so you can log in and you can ask them for help in navigating, even within the building. You can say, hey, where's the nearest restroom in this building? And it'll say to the right, down 100 feet or something like that. Major centers, like I believe Detroit Airport, Walgreens offers it for free for more than 5 minutes. And all the others are, Be My Eyes, for example, is a volunteer app program. So when you log into when you ask the app, a sighted person is on the other side. So if you have a can of soup or whatever, and you want them to read, the sighted person, you hold up your phone camera to it and the sighted person can read for you. And there's color identifiers as well for patients with who are not able to do that. So you'll see some patients who might be using these apps in the clinic. Okay, so we want to optimize vision if they have any and enhance safety. So just to start, bottom right is our former O&M instructor, and he was taking patients, navigating our bus system and how to use the light cane. So lighting optimization is something we do on a clinic. We do test them to see what the optimal lighting is. The other thing we go over with patients is, and for our intents purposes in the clinic, the hallways need to be obstacle free. So in the hallway, if there is a stool or chair in the hallway, which sometimes we have because our computers on wheels is in the hallway, we have to be careful that we try to clear the pathway for the patients. And high contrast would be good. For example, the doors that you don't want the patients to go into, ideally it would be the same color as the wall. And the doors that are for patients, ideally would be a contrasting color. And of course, in the building, we want to reduce glare, and the patients can wear their indoor filters. So we have patients with varying filters because, they have one for snowy, sunny day, which is very, very glary. And a lot of patients have complaints about places like Myers or Costco because of the fluorescent lighting just creates so much glare for them. So some patients will come in wearing a lot of these filters. Contrast enhancement, something that we can think about in our clinics, like this is just stairs, right? You can imagine if you didn't have the black, I don't know what you call them, the stickers or whatever, it's difficult for them to navigate the steps and know when to stop. Keyboards. So a lot of patients, everybody's on the computer, everybody has keyboards, and this is a high contrast keyboard that we can recommend for our patients. So start thinking about that as you think about our clinic setting. If it's something that we want the patients to see, high contrast is the best way. Adaptive markings, that will teach them about high contrast markings on appliance dials or their cell phones, or even their remotes. Medication management pertains to us for sure. So this is a talking glucometer, and the syringe, when they pull the insulin, it clicks. So every click is, for example, millimeter or whatever you set it to. So these are things that we can recommend for patients. And most of this is done by our OT on this page. Actually, we have a low vision's OT, Ashley Housen, who does this with our patients in her room. She does make home visits as well. So Renee talked about asking the patients, everybody's different. Some people, even though they have very minimal sight, they're very independent. They want to do that themselves, which is great. And so our job is to ask them, how can I help you? And allow them to tell us what they need. So paperwork, if it's paperwork, recommend large and bold print. We're still not doing that very well, I think, at Michigan Medicine, even in Kellogg Eye Center, or we can read to them. Navigation. I have a video at the very end about what Renee mentioned. Don't take them, don't drag them around. And it's a very good introductory video. And feel free to Google more for that. But I'll show it at the very last slide. Navigation. So patients will ask, hey, where's the, can you tell me where the restroom is? And we're so used to saying just down the hall to the right. But patients with minimal sight, this doesn't make any sense to them at all. So the best way is to say, hey, I'll take you, and just walk them down the hall and take them to the door. Renee has a guide dog, and in Michigan, it's called the leader dog in Rochester, Michigan. And one of the things that I wanted to make sure we all understood is that we never pet a guide dog who is working unless you ask the owner, unless it's permitted. So patients that are in my chair with the dog just sits next to the exam chair quietly, and it's just like as if it's not really there. But we never talk to we never pet the dog unless we're the owner's okay with that. And we don't coax the dog in any way because they're trained for intelligent disobedience to protect the traveler. So for example, patients like Renee, who has no sight, will start to walk, but the dog is trained to say no and hold her back when there's a car coming out that she doesn't know about or that she didn't hear. So we don't interact with the dog. Now, there are such things as guide horse. We did see one in our lobby years ago. And I did a double take because I had not known of it, but there is such a thing. The horses, the advantage of the horses are they live longer. They can live up to about 40 years. So you have a few decades with them as your guide animal, versus dogs are probably, you have to get new ones almost every 8 to 10 years. I don't know how they care for it. I don't know if they need a barn or anything for the guide horse. So I don't know anything about that. It's support groups. Some patients will have the support groups. We could recommend them. They're national support groups, prevent blindness, with a lot of great resources. We had one before the pandemic. We had a support group for our patients as well. Okay, so this is the slide, and I'm hoping that you can see this. This gives you an introductory idea of how to guide patients in our buildings. Let me know if you can hear it, okay?
Introduction to Sighted Guide. Many people with vision loss feel comfortable traveling independently, either while going to work, shopping, banking, or just visiting friends. But there may be times when a sighted guide comes in handy. For example, in crowded situations like office parties or street crossings, in unfamiliar places, or if the person has recently lost their sight and are just learning to get around. Whether you're encountering someone with vision loss as a family member, caregiver, staff person in a nursing home or hospital, or even as a friend or coworker, this series of videos will provide you with the skills and confidence to guide someone comfortably, respectfully, and safely. Whenever you're guiding someone who is blind or partially sighted, it's important to remember to describe your surroundings, like the size of a room, positioning of a door, in detail, whenever possible, to help the person you're guiding better understand their environment. Speak directly to the person you're guiding when you're addressing them. Observe the person and be empathetic if they display any symptoms of nervousness. Stop walking before you approach obstacles or unusual terrain, so that you have time to describe them to the person you're guiding. For more help about living with vision loss, please visit www.cnib.ca or contact.
So I'm going to stop sharing and see if you have any questions. There's more in that series, so you could Google them. There's a lot of really good details, but that just gives us a start. Do you have any questions, comments?
Thank you, Dr. Day. So in regards to some of the tips and strategies you talked about in the clinic, what technology are you currently using? I know you're trying to navigate the firewall, because I know some of these technology, some of the tools are unavoidable for some of our blind and low vision patients. Do you offer any tech, like assistive devices for them while they come into the building?
In general, they can get onto our guest Wi-Fi, I believe. We don't have a lot of patients in the East site, but I have not heard from patients if they needed to use an app that they were not able to use it. I think what we're trying to do at Kellogg too is to see, do we have enough staffing or volunteers where we can start guiding patients when they enter the door?
And then my second follow-up question, which I'll show shortly, the disability accommodation tab that we have in our MyChart, which is electronic
Mhm.
health record. For those of you who are not familiar with, Michigan Medicine has a MyChart, and there is a tab, a disability field that lists the accommodations. Could you share some feedback on how that's worked or has not worked for you and your staff?
Well, it would be helpful if we entered things. That's the thing, right? Because we're so into like just getting the work done, getting the patients have been waiting so long for us. And so I keep thinking I need to go back and enter the accommodations for patients, but I personally do forget to do that. It'd be great if any of our staff could remind us or to help us do that. And so you could say they're blind, they're vision impaired, do they need large print, do they need wheelchair service? Yeah. So I think it'd be great if we could do that.
Well, thank you so much for your input. So I'm going to just kind of briefly talk a little bit on some of the experiences I've had on the primary care setting, and then we'll open it up for questions for all of us. So I'm going to just briefly share the disability accommodation, that disability field I mentioned, because I think it is a powerful tool. I do agree. We still have some implementation issues, and I have some thoughts on that. So let me just share this real quick. Okay, can everybody see this? Oops. So the disability accommodations tab has been built, it's gone live. One unique feature that we have done is that this actually gets submitted to the portal. So we heard Renee does use the portal, and they can actually fill out this questionnaire on their own before they come to the appointment. So this is part of the e-check-in. And Dr. Day, I'm happy to kind of share a bit more. We're trying to roll this out for different clinics and different departments to do that. And so this is a powerful tool to at least start getting a better sense of what disability they may have. In some cases, they call it a limitation. The other important thing is to understand what their needs are. So one of the strategies with this standardized patient program, it's being mindful of the disability status, the type, and what accommodations might be required to make sure that the visit is healthcare accessible and effective. So this is a powerful tool. If you have not seen it, please interact with it. We are all champions of this. We're all advocates for this. And I'm hoping that this will continue to expand. And so this is one of the powerful tools that we have available in Michigan Medicine. The second, we saw the human guide technique, a wonderful video. One of the things that we do have here is the Hope Ambassador Program. Dr. Tyler James has already provided training for some of our ambassadors. So those patients who may require a human guide, there are ambassadors who have already received this training, can help navigate, especially in the hospital setting. I have trouble even trying to navigate the hospital, let alone somebody that may not have access to a lot of the information or signage. So it's called the Hope Ambassador Program. You can reach out to them, and there are some that have received this training. So I'm going to stop sharing. So as a primary care physician in family medicine, one of the really key things that I tried to emphasize across different types of disabilities is to get a better sense of the individual, not make assumptions. Renee was very clear that often we make assumptions and we're often wrong because of our limited awareness and limited training. So ask the patient directly, get to know them. It's okay to be humble, express some of that cultural humility to get a better sense of who they are, their disability type, as well as any care needs. So when you get that information, be intentional with that information. Don't just simply get that information, don't act on it. We are all human, we make mistakes, but it's important that we try to be proactive in meeting their needs. The other thing is, once I get that information, I've had varied experiences with patients who is more limited, where they may have tunnel vision, some patients who have no vision. And so the strategies may vary based on their needs. But some general good strategies that I try to incorporate with everybody is just kind of give them a heads up what I'm going to be doing. Renee mentioned that it was very distracting to hear this typing. So what I tried to do is say, I'm going to head over to my laptop or my computer, and I'm going to go ahead, pull up the lab results from last week. And so that's a good practice to do anyway, because patients don't like these pauses, the loss of eye contact. So it is very helpful to provide some description what you're about to do. It offers transparency and it helps to engage these individuals as well. And then the other thing is walk them through what you see. So an example recently was the child growth charts. So kind of talk about, okay, it looks like you're growing well on your growth curve. Your weight is at this percentile, your height is at this percentile. So kind of verbalizing what you see is another powerful strategy to make this more inclusive and accessible. When we have patients come in, one of the things that's always a good idea is to have them bring their medication for medication reviews. There are different strategies that patients do. Some people do rubber bands, so it's like multiple times a day, 2 rubber bands if it's twice a day. Some used even buttons. We saw the script reader. There are different strategies. Some of them are manual, some of them are going to be more reliant on apps and technology. The other thing is approach the patient, verbalize what you're about to do. So it could be very simple. It's, okay, I'm going to get my stethoscope. For me, I have an assistive device that makes it louder, connect with my cochlear implant for streaming. So there's a couple additional steps. And so it looks different. So naturally, I have to kind of describe this for all. But it's a good step to say, okay, let me get my stethoscope turned on, connect to my cochlear implant, and I'm going to take a listen to you. So that way they know I'm going to approach. I'm going to be putting on a stethoscope, hopefully not too cold, and be able to listen to their lungs, their heart, as well as mention, I'm going to check your ears and mouth. So that way you're kind of guiding them so they know what to expect. It's also really important to help introduce yourself, the name tags. We heard that as well. That's easily forgotten. And so it's important to come in and say, hey, I'm so-and-so, and also I have a medical student with me. Introduce the student so that way they're not sure if there's somebody else in the room. So that way they know if they feel comfortable to disclose certain information, they know who is in the room as well. The other important thing is give them some sense of closure. So you are closing the computer, give them a summary of what we're going to be doing, what our next steps are. Make sure you understand how we can get that information relayed. Talked about portal or email. Our Michigan Medicine MyChart, there is a feature that you could do a large print for after visit summary. I use that from time to time. So that way, if they have some limited vision or low vision, they may still be able to benefit from a large print. So find out if it's going to be requiring a screen reader, maybe they want it emailed, try to accommodate those. I have also used Word documents to make really, really large fonts. So it's important to engage. And then as the visit wraps up, give them a sense of closure. I am going to get up and leave. So that way they're not stuck in the room waiting. Is it time for me to leave? If somebody is so in the room. So those are just some tips for me. I engage the low vision rehab clinic. I use you guys a lot. We do have some also with deaf blind. And so keep in mind that many of our low vision or blind patients may have dual disabilities. So we have, for example, some patients with Usher syndrome. So we have deaf and blind. In some cases, we also need to use tactile sign. So there may be varied communication strategies, and sometimes the interpreter will be requested if you are not familiar with the sign language. So those are some general tips from a primary care perspective. So I'm going to pause because we have a couple of minutes before we close if there are any additional questions.
I had a quick question for Dr. Day specifically. You had mentioned that there was kind of slow uptake of even simple assistive techniques like large font on documents, for example. And I was just curious if you were aware of or know of any specific routes by which we can more easily advocate for simple changes like that, which I imagine most people would be willing to uptake if they're aware how much of a need there was for it, but just channels to sort of make that need known more widely amongst faculty and students.
You mean at Michigan Medicine?
Yeah, sorry.
Yeah, so we've had conversations with some of the media. I'm thinking about the websites. We've had some conversations with them. So, and this is a couple of years ago. So I'm not really sure where that is in terms of changing. What we wanted to see was at least the option of clicking on the large print. I'm sorry. Of clicking onto large print for some of the websites. So unfortunately, I don't know where that is in the process, but yeah, that'd be good.
Well, I want to thank everybody. I know Renee had to drop off earlier, but I want to also thank her for joining. Dr. Day, thank you so much for taking the time out of your day to provide your insights and feedback. I really value you as a wonderful collaborator and try to advocate for access across our healthcare services institutions. And I do want to acknowledge Josie, thank you for your help. Andy, thank you. And also Letty for the captioning tonight. So this will be available. We'll just kind of edit the video footage and will be a resource. And as you saw in the chat box, there will be a tip sheet available that will be a resource for people who want to kind of figure out what are some strategies to make our healthcare business more accessible for low vision and also blind patients. So thank you, everybody.
Thank you for having me. Bye-bye.
Everyone.